Good afternoon and welcome to the second assembly of the newly branded Tisch Cancer Institute virtual seminar series. I am Jerry Chibik, and together with Amaya Lujambio, we co-direct this weekly event. Last week, we had over 150 participants, which is encouraging that this new virtual platform will be well attended and have a positive impact in the TCI community. This week, our invited internal speaker is Dr. Robert Orrin Wright. He is the Ethel H. Wise Chair in Environmental Medicine and Public Health, Professor of Pediatrics and Environmental Medicine, System Chair in Environmental Medicine, and Founding Director of the Institute for Exposomic Research. Dr. Wright is a pediatrician and environmental epidemiologist with more than 20 years experience working in children's environmental health. And as director of the Lautenberg Laboratory, Dr. Wright oversees a highly unique research group that is among the first to combine analytical chemistry capability to measure an array of different exposure biomarkers with cutting-edge technologies in epigenetics. Dr. Wright joined Mount Sinai in 2012 with the vision of establishing a laboratory that integrates state-of-the-art methodology in exposure science with epigenetics and molecular biomarkers of effects. He has published over 200 research studies, most of which dealing with environmental health, and he has served on numerous international and national committee and advisory boards. Dr. Wright is a graduate of the University of Michigan Medical School and completed a residency in pediatrics at Northwestern University, as well as fellowships at Brown University and Harvard University. On behalf of the TCI, I wish to thank you for accepting our invitation to share your research with our community. And before turning the virtual platform over to Dr. Wright, I also want to remind our participants that we will open the discussion to our attendees at the end of the presentation. We ask that you utilize the chat feature to propose questions, and Dr. Lujambio will chair the post-presentation discussion by selecting questions. Also, please be sure that you are muted during the presentation to prevent unnecessary disruptions. Dr. Wright, thank you again, and let's switch to your screen.
So are you seeing my screen now?
Yes.
Wonderful. Okay. Thank you for that introduction. I give this talk sometimes as an invited speaker, so it's nice to show this photo of Mount Sinai. Obviously, everyone here knows what we look like. Right now, there's a tent somewhere to the right of those buildings. It's a reminder of where we are in time. So the title of this talk is The Exposome and Precision Medicine, and the subtitle is actually stolen from a Flannery O'Connor short story called Everything That Rises Must Converge. I like the idea of juxtaposing exposomics, which is a new field, with precision medicine, which is a new field that's sort of rising in parallel with each other, which is what the title suggests, although if you've ever read Flannery O'Connor's work, that's really not anything at all what the story's about. I'll let you read it. So the outline of the talk is, I'm going to tell you how exposomics can be used to understand health and disease. I'm going to talk a little bit about precision medicine, which I think this group is very familiar with. I'm going to make the argument that precision medicine has largely been ignoring the whole field of environmental health, not just exposomics. But at the same time, I think we are making the mistake of largely ignoring precision medicine, and there are ways that we can integrate and work together and converge. And now is that time. So I'll start briefly with the definition of precision medicine. The NRC definition, National Research Council, is the tailoring of medical treatment to patient characteristics, creating susceptibility classifications for disease, its prognosis or response to treatment, so that you could individualize interventions. Presumably that would maximize benefit, reduce treatment failure, and reduce side effects. What it really means is we want to understand each patient's individual background, because that background will actually influence disease progression and treatment response. And it operates in a setting where the probability of illness is 1. That is, prevention no longer matters. And that's an important point because I come from the public health world, and we don't actually operate in that sort of a setting. We actually operate in a setting of there is an exposure, there's a risk factor, there's a probability that you might get a disease. In medicine, the probability is 1. That is, the disease exists and we're dealing with that situation. It actually gives you a different perspective when you think of these two different scenarios. So what is exposomics? So exposomics is really the study of all the health relevant environmental factors across the lifespan. So it's constantly changing. It starts from the moment you're conceived and it doesn't end until the moment you die. And it's not just chemicals. I come from a toxicology background. So obviously I'm very interested in the effects of chemicals on the human body, but exposomics is really more than that. It's the social environment, it's the nutritional environment, and it's the physical environment. And it's the interactions of all these environments with each other and their interactions with our genome. So it's not just chemicals, which is sometimes a mistake that people think when they think of environmental health, because environmental health tends to be a little more toxicologically based, but the exposome is really all the relevant environment. In fact, in this day and age, it probably should be included the infectious environment as well, because obviously with COVID-19, that's another background in which environmental factors occur. So I used to listen to a lot of punk rock. It's very hard to find an Iggy Pop quote that you can actually put on a screen without getting in trouble. But Iggy Pop once said, it's very important to know what not to do. And so what are we doing in precision medicine and what are we not doing? So precision medicine, I'm going to argue, is largely practiced as a pharmacogenomic field. The idea is if we understand genetic variation to treatment of disease, we can then target therapies to the most effective drugs, improve efficacy and decrease toxicity, and target even behavioral modifications for people with particular susceptible genomes. That way we can improve counseling and decision-making, improve outcomes and patient satisfaction. But it's only going to work if we practice it as a pharmacogenomic field if genes are the only source of variation in treatment and prognosis. And there's very little evidence to suggest that that's the case. And in fact, I think we all know that that's not the case. So this is a typical precision medicine website for a university. I won't name which one it is, but these websites that you scan, and virtually every major American university and medical school has a precision medicine program with a website. You'll always find a mention of genes, and you'll always find a mention of gene-targeted drugs, and usually some sort of diagram that represents the genome or genes, and how by genotyping or sequencing people, we're going to figure out the best drugs for them. But we know that genetics is only one piece of a much larger puzzle. And for most programs in genomics, or excuse me, precision medicine, there is no mention of environment. This is another one. Here's the DNA symbol, here are the drugs, here's the risk stratification. And another one, instead of horizontally oriented, this one was vertically oriented, where we have the DNA and there's the risk stratification. And we use genomics to stratify people. No mention of environment. But we've known that it's not just the genes for a very long time. This is the cover of Science in April of 2002. And the title of the issue is The Puzzle of Complex Diseases. And complex diseases are the diseases that we're most interested in. And they certainly include cancers. They include things like Alzheimer's disease and asthma and autism, obesity, virtually all of the major drivers of healthcare costs in developed countries, including the United States, are complex diseases. And their etiology is a mixture of genetics, certainly genes. I'm not suggesting genes aren't important, but there's other important factors. They include behavior, they include nutrition, they include infections, chemicals, the physical environment, culture and society, and stress. All of those things were discussed in this issue of Science. And in fact, the introduction to the issue was entitled, It's Not Just the Genes. And this was in 2002. So another punk rock reference. So how did we get here? David Byrne from the Talking Heads. Well, as I mentioned, we're interested in complex diseases, and this is just a small list of the many different complex diseases that are very important drivers of healthcare costs. ADHD, obesity, asthma, COPD, renal failure, Parkinson's disease, cancer, et cetera, et cetera. The list is very, very long. We know that their etiology is a mixture of genetic and environmental risk factors. There's no particular genotype that predicts any of these diseases, and there's no single environmental risk factor that predicts any of these diseases. They're rising in prevalence and annual incidence. That is, most of those diseases are actually becoming more common over a relatively short time span of 20 to 30 years. If it's only been 20 to 30 years that they're increasing, then genetic main effects cannot explain the rising rates. Doesn't mean genes aren't involved, but if a disease is more prevalent in 2020 than it was in 1990, there is no way for genetics to explain that rise. And most of those diseases are more prevalent now than they were in 1990. That means environment has to explain the increase in their rates. I know there's controversy over autism, whether it's increased surveillance or increase in disease, but many of those diseases, certainly obesity, there is no indecision in whether or not they exist. They're measured very, very precisely, and they're clearly increasing. Yet we tend to focus on the genomics of obesity rather than what are the environmental factors that are driving it. And the environmental factors are clearly driving the increase. And I would argue that the way we do research actually creates barriers. I'm not a fan of heritability estimates. Heritability estimates, I'm sure you're all familiar with them, they actually try to parse out the percentage of a disease that's due to genetic factors and the percentage of disease that's due to environmental factors. In most diseases, certainly complex diseases, genetics is not actually causative, it's a risk factor. And by the same token, environmental factors are not truly causative, they are risk factors. That is, if you have a particular genotype, if you have a particular environmental risk factor, there's a probability that you'll get sick, but there's certainly no, it doesn't define the illness. And the levels of risk vary for both the genetic and the environmental risk factors. So we tend to think of diseases as being either or. Even if we know that they're a combination of them, we try to parse out that percentage that is actually genetic versus that percentage which is actually environmental. And I think this is actually creating a situation where we don't actually think of the interactions between genes and environment. So I actually believe that all diseases are due to the interactions of genes and environment without exception. Even Mendelian diseases are due to gene-environment interactions. And we actually can illustrate how this actually plays out. And I'm going to make the argument that if that's correct, that all diseases are due to interactions between genes and environment, if the genetic polymorphism is relatively uncommon in a population, and the environmental factor is very common in a population, our perception is that disease is genetic. By the same token, if the converse is true, if the environmental factor is very low in prevalence and the genetic factor is very high in prevalence, the perception that we have is that this disease is environmental. Even though the biology may be identical in two different populations, the perception changes. And this is a concept that's hard to show in people, but is actually quite easy to show in chickens. This is an actual example. It's actually from a textbook that Ken Rothman wrote on epidemiology called Modern Epidemiology. And there really is a trait in chickens called yellow shanks. So yellow shanks is a discoloration of chicken legs with a particular genetic variant when the chicken eats yellow corn as opposed to white corn. And it follows an autosomal dominant inheritance pattern. So imagine two farmers, Farmer Jones and Farmer Smith. They live down the road from each other. So Farmer Jones has an inbred chicken flock. All of his chickens carry the variant for yellow shanks. Therefore, his family has been feeding them white corn for generations because yellow shanks reduces the price at market. One day the store runs out of white corn. He has to feed them yellow corn. All of the chickens get yellow shanks. If you were to ask Farmer Jones, what's the cause of yellow shanks? His perception is yellow shanks is an environmental trait that's caused by eating yellow corn. Down the road, there's Farmer Smith. He has an inbred chicken flock. None of them carry the variant for yellow shanks. Yellow corn is cheaper, so his family's been buying it for generations. It feeds them yellow corn. None of them ever get yellow shanks, and then one day, one of them gets yellow shanks. It's a new mutation. He's an amateur geneticist, so he follows the pedigree of that chicken. He finds that half of his offspring get it, and of the ones that don't, none of them get it, and the ones that do, half of their offspring get it. And he plots the pedigree, and he determines that yellow shanks is actually a genetic trait that follows an autosomal dominant pattern. So which is correct? Is Farmer Jones correct? It's environmental. Or is Farmer Smith correct? It's genetic. Or is it completely due to the prevalence of both the exposure and the genetic trait in these two populations? So if yellow shanks can be either environmental or genetic, is cancer truly environmental or genetic, or is it a combination of both? And we do a disservice when we try to think of it as being 50% genetics and 50% environmental, or whatever the heritability estimates turn out to be. And by the same token, even Mendelian traits follow this pattern. Think of phenylketonuria. Is it really environmental, or is it really genetic? If it's genetic, how come we can change the environment and actually change the phenotype? And even other diseases such as cystic fibrosis, which is sometimes, people will argue, well, cystic fibrosis doesn't follow that. Well, the counter argument I make is that it's really hard to avoid sodium and potassium. So because the environmental factor is so prevalent, cystic fibrosis has the appearance of being genetic, even though it is at some level a gene-environment interaction. And so what is the real heritability of chicken shanks? Is it 0% in Farmer Jones's case, or is it 100% in Farmer Smith's case, or is it completely contextual? And maybe all complex diseases are contextual. And then whenever we estimate these heritability estimates, it's actually not all that surprising that they vary from population to population, because all genes operate in variable environmental backgrounds. And there are lots of backgrounds. Nutrition is a background. Whether or not you are exposed to a chemical and you're obese may change the metabolism of that chemical, particularly if it's fat soluble. If you have vitamin or mineral deficiencies, it may also change the way you metabolize chemicals, or drugs for that matter, treatment drugs. Pregnancy can change metabolism. Geography can change your response to environmental factors, things like temperature or allergens. Also altitude. If you live in Colorado, a mile above sea level, you're likely to have a slightly increased hemoglobin. That slightly increased hemoglobin slightly increases the viscosity of your blood, which causes a slight increase in your risk for stroke as you get older. Culture can obviously play a role in disease, whether or not culture determines the food you eat, and your social networks and your social supports. Nobody's really exposed to a single chemical. All the children who ever been exposed to lead were exposed to other things. So what we're really measuring in a study of lead poisoning is actually the interactions between lead exposure and their overall environment, including their social environment, as well as their genetic environment. And then health changes disease. In fact, health may be the most important background in precision medicine, because it changes the way you metabolize a drug. It can actually change your response to a drug, and it can change whether or not you get exposed to environmental chemical, whether or not you get sick. When I was an intern in pediatrics in the 1980s, we used to give aminophylline, which is a type of theophylline for asthma attacks. And if a child had influenza infections, they actually slowed the metabolism of theophylline, and they may get theophylline toxicity. And it was actually due to the influenza infection. So the background in that case that was important was an infectious background. So health may be the most important precision medicine background. So here's some examples. This is sort of the classic pharmacogenomic precision medicine example. So a 53-year-old develops a deep venous thrombosis on a trans-Pacific flight. She gets started on warfarin and she develops a GI bleed. So she has a genetic variant in the P450 system that causes her to be a slow metabolizer of warfarin. If she had had a genome scan, it would have been detected and she would have got started on a lower dose, and this complication would not have occurred. So this is an excellent example of how genomics can help in precision medicine. It's a real example, and it's something that we should be doing. But what about this example? A 17-year-old child who has autism has a notable increase in head banging and anger outbursts. If we were to do a genomic screen on this child, we would not find anything that might explain his increase in head banging and anger outbursts. And in fact, it's a new onset behavior. It wasn't there 6 months ago. This is an actual patient I once took care of. Turned out he had lead poisoning. Now, what's unusual about this is, one, he's 17 years old. You don't typically see 17-year-olds with lead poisoning. Lead poisoning usually occurs from the normal hand-to-mouth behavior that toddlers have. He actually had a toddler sibling who did not have lead poisoning. So typically, if you live in a home that's old and there's a lead-based paint and there's dust in the home, it's the 3-year-old that would get lead poisoning, the 17-year-old would not. The exact opposite happened in this situation. And the difference was he has autism. Children with autism frequently have pica, meaning they eat non-food substances. It turned out he was eating newspaper, and newspaper ink has a little bit of lead in it. But if you eat enough of it, you can actually get lead poisoning. That's what happened to him. So we were actually able to treat his lead poisoning, and we discovered what the source was, and the family got rid of all the newspapers. This was obviously in the 1990s. Nobody has a newspaper anymore. So I'm not sure this example actually holds anymore as newspapers go out of business. But that's an example of how pica and autism might actually predispose someone to lead poisoning, and something where a exposomic screen might have detected what was happening, but a genomic screen would not have. And here's some more examples. So a 14-year-old has gastroesophageal reflux. He has a history of depression, and he's treated with morphine for a fracture, and he gets respiratory failure. So there's a couple of clues here. He has GE reflux, so maybe he takes over-the-counter Tagamet. Tagamet is an inhibitor of the P450 system. It would work similarly to have a genetic variant in one of those genes, but in this case, it's actually due to the drug that actually inhibits the enzyme. He also has a history of depression, so he's on Paxil. So if he's on Paxil, it's another P450 inhibitor. So P450 system is needed to metabolize morphine. He's a slow metabolizer of morphine. He got too big a dose, and that's why he developed respiratory failure. So a genome scan would not have picked this up, because there were no functional variants in the phase 1 or phase 2 genes that would have affected morphine metabolism. But an exposomic scan would have picked it up. So what are the most important backgrounds in precision medicine? I would argue that it's actually not genes or environment, but it's disease and treatment. We want to understand how genes interact with disease and treatment, and we understand how environment interacts with disease and treatment. And we need to start doing studies that physicians need to treat patients. And that's actually as much a public health versus a medicine issue than it is a genetics versus environment issue. It's actually understanding what the questions are that physicians need in order to treat patients. Right now, I'm going to argue that many people, particularly in the environmental health world, are not doing those kinds of studies. And I could say actually in the genetics world, a lot of it is more of a public health perspective. So here's the medical perspective. So if I'm taking care of someone, I want you to help me diagnose the patient, and epidemiology helps, environmental epidemiology helps. If I understand that smoking is a risk factor for heart disease, and a 53-year-old male comes in who's an ex-smoker who has chest pain, I'm going to weigh that in and suggest he's probably having a heart attack. But in terms of treating the patient, these sorts of epidemiologic risk factors often don't help. In fact, I may even ignore the results in the way I treat people. So if I'm a smoker and I have chest pain and I'm having a heart attack, it's not going to change whether you give me nitro and aspirin, and whether or not you do a catheterization, or whether or not you're going to do surgery on me. That's irrelevant at that point. So that risk factor doesn't help with the treatment. So what we're not doing is understanding what are the genetic variants and the environmental variants that actually affect the way we treat people, which gets a little closer to the pharmacogenomics, but I'm going to argue that there also needs to be an exposome pharmacology issue, pharmacoexposomes. So Ursula K. Le Guin is a famous science fiction writer, so there are no right answers to the wrong questions. And I would actually argue for precision medicine in exposomics, and sometimes even in genomics, we're not asking the questions that actually help physicians take care of patients. So what are the roadblocks? So in medicine, we talk about individual people. We're interested in diagnosing whatever it is that brought them here. We know that there's a problem. People don't go to the doctor randomly. We may not know what that problem is, but we know that a problem exists. And then we want to choose treatments. We want to reduce the side effects. We want to have the best possible outcome. But if you're a public health scientist, and I also come from a public health world, the perspective is slightly different. We want to understand what's happening at the population level. We're talking about risk factors. If you get exposed, will you get sick? There's a probability rather than a definite certainty of illness. And we're talking about prevention. Prevention is very, very important. I don't mean to downplay it, but it's a different scenario than what the physician and what medicine faces. And we're talking about susceptible populations. Perhaps women who are pregnant who get exposed to a particular drug may actually be vulnerable. Their unborn baby may be vulnerable for a teratology issue. So medicine starts after a person is sick. Public health starts before a person is sick. And I think that's where some of the tensions lie between the two fields, and why what public health researchers do can't always be applied to the way we treat patients. Because outside of primary care, medicine is less interested in why you are sick rather than how to treat you. And I think it looks something like this. So if you were to compare public health research with medical research, public health research on a timeline almost always occurs before the disease starts. So this little hash mark is where a phenotype becomes present, and to the left it's not present, and to the right that it is present. Most public health studies are either prospective cohort studies that predate the onset of the phenotype, or they're case control studies that may start after the phenotype arises, but are trying to go back in time to figure out what happened to you before you got the disease to predict that health outcome. And genomics actually fits well in the case control design because your DNA sequence doesn't change over your lifetime, so you can be certain that if a genetic variant is associated with a particular disease, that it existed before the disease existed. And in medicine, what we're really interested in is how to treat the patient and how to diagnose the patient. So typically you're doing a randomized controlled trial. You're looking at different treatments and their effects and their side effects, or you're doing a clinical observation study to see whether or not a particular treatment actually causes a disease to progress faster than otherwise it would, such as Alzheimer's disease. Some diseases just aren't curable. Oh, there it goes. So in public health, we're talking about causation, we're talking about risk factors, and in medicine, we're more interested in diagnosis and treatment. So the goals of the research are actually quite different in public health versus medicine. And for precision medicine, we really need to zero in on this idea that we want to study diagnosis and treatment. Because most precision medicine studies really should start after the disease onset. Then move forward in time and assess disease progression and response to treatment. So in summary, if we were to compare public health to medicine. In public health, we're looking at causation. We want to know whether or not a particular genotype is associated with the disease, or a particular environmental exposure is associated with the disease. It sometimes gets complicated because diseases aren't uniform. So Parkinson's disease isn't a disease, it's a series of different phenotypes. There are subphenotypes, and the cause of one phenotype may be different than the cause of another phenotype, even though clinically they look very, very similar. This tends to complicate research. This is a big problem in genomics. However, if you're thinking about response to treatment, maybe it's less important. Maybe it doesn't matter how you got to this Parkinsonian-like state or phenotype. Maybe if you get exposed to a neurotoxic chemical, you're going to have the same sensitivity that whether you had phenotype A or phenotype B to that neurotoxic chemical, because that chemical is toxic to the brain. So non-specific phenotypes may actually be less important in this type of research paradigm. So in public health, we need to go back in time. You want preclinical samples if you want to understand causation, because you have problems with confounding by indication otherwise. In medicine, or precision medicine, maybe time travel isn't necessary. Maybe all you have to do is measure environmental factors that occur after the disease onset and see whether or not they make the disease worse. So you actually want to sample concurrently to the state of the disease. So it's actually a little simpler to do. You don't have to go back in time. In public health, you have to counsel at the population level. And I think any physician will tell you that if I tell a patient who doesn't have heart disease or lung cancer or COPD to stop smoking, it really doesn't work very well, because people who are not sick just don't listen. On the other hand, once somebody has a heart attack, when somebody gets COPD, when somebody gets lung cancer and you counsel them to stop smoking, it's very, very effective, because it's actually a matter of life and death at that part. So sick people listen. Healthy people are also hard to recruit and retain. So if you ever do a healthy cohort study or prospective cohort study, you'll probably realize that this is very, very true. And in fact, in case control studies, the cases are easy to recruit. The cases are easy to retain. It's the controls that are harder to recruit and harder to retain. And that's something that is true of every case control study, because healthy people just can't be bothered. Sick people, on the other hand, they have a high recruitment rate and high retention rate. So if we're just interested in disease progression or response to treatment, and we only recruit people who have a disease, those are actually easier studies to conduct. And in public health, as I mentioned, you need a control group. I would actually argue you don't need a control group if you're just doing an observational, even if you're just doing an observational epidemiologic study of people with a disease, you actually only need to study their progression and their environmental exposures if you want to understand how those environmental exposures impact the disease. So why now? So why do what I'll call precision exposomics? Well, there's actually been exponential advances made in exposure science in the last 10 years. And this is just a brief list of them. So we now have untargeted chemical assays. So this is actually something we do in our institute and in our laboratory. So these are really the same technology that's applied to metabolomics, but the technology is getting better and better. So we now have high resolution GC mass spec and high resolution LC mass spec. They get different kinds of chemicals, whether it's gas chromatography or liquid chromatography. And we can actually analyze tens of thousands of features, which are chromatographic features, reproducible in biological samples. And we don't even have to know what they actually are. We can actually analyze them at a statistical level as the reproducible feature to try to identify those features associated with the disease. And once we identify a feature associated with the disease, then we can hone in on identifying what it is. So it's actually sort of a different way of thinking about how to do research. And as these databases and these libraries grow, we're actually able to identify more and more of these features. And in fact, with mandatory data sharing, which NIH is doing now, I think you're going to see a big increase in the size of the different libraries that people use, and the number of chemicals that you can actually identify is going to increase. Also, if you've ever done a high resolution metabolomics analysis and you save your data, we can actually go back and identify features that were unknown at the time that you did your analysis, because they've been discovered and ID'd since then. We're also doing higher dimensional targeted chemical panels. So in our laboratory, we have a panel of chemicals on 0.2 mLs of urine. We can actually measure over 150 chemicals, and it's fully quantitative. So we know the exact dose in the urine. We can also do similar ones in plasma. Untargeted chemical assays, I talked about a little bit earlier, are semi-quantitative. So they're not truly quantitative. Targeted chemical panels are actually purely quantitative. And there's other ways to measure environment that don't necessarily have to do with laboratory assays. So there are satellites that circumnavigate the globe. This data is publicly available. So satellite remote sensing is becoming a big way to measure environmental factors. And there's a lot of them that you can actually measure with satellites. Air pollution on a daily and in some cases hourly basis on very small grids, as small as about 600 meters squared. Right now, our team actually does 1 meter squared air pollution estimates for the entire New York metropolitan area. And we've gone back to about 2010, and we can actually go back in time to when the satellites went up, which was in the late 1990s. So we're actually working on that. This is actually a big data issue that our models have literally billions of data points, because we're going back in time and we're covering a very, very large spatial grid. So it has both a temporal and a spatial variability. We can do the same with temperature. We can actually estimate temperatures in 30-meter grids. And so there's a lot of interest in the role of climate change in health, and that's something that we're also working on. Obviously, these satellites can actually estimate green space. It can estimate light at night, which can change circadian rhythms. So we can look at a lot of different environmental factors using satellite remote sensing, and we can even go back in time with satellite remote sensing. So there's a lot that can be done with public database mining. You can mine census data to get ideas of the socioeconomic status of a particular neighborhood. You can actually mine Google Maps to get an idea of food deserts, or where or more recent, whether there's fast food areas that are approximately where people live, or whether there's more healthy food choices, or whether there's walkability scales that you can create for the neighborhoods that people live in. All those things can be mined with public databases. We can get a lot of environmental data out of EMRs. So we think about it in terms of phenomics or measuring phenotypes, but whether or not you're on a particular drug is generally recorded in your EMR. Whether or not you've had knee surgery is going to be recorded in your EMR. That's a type of environmental exposure that may be important to your health. And those are things that we can also mine as well from these databases. And then wearable devices are becoming more and more commonly used. You can measure physiologic measures such as heart rate and distance walked, and physical activity with wearable devices, but there's even some wearable devices that actually measure environmental chemicals. And all this is possible because of the big data computational infrastructure through the growth of genomics. So we're actually piggybacking onto that computational infrastructure when we do exposomic analyses. So in summary, public health has been interested in studying vulnerable populations, but I would argue that we've actually been guilty of ignoring people with the disease, because we're so focused on causation that we don't think about whether or not somebody with the disease may actually respond differently to environmental chemicals. So for an example, we think of phthalates, which are found in plastics, as being an obesogen. And there's good data that they actually are endocrine disrupting chemicals, and they actually may make you metabolize both fats and glucose differently. Well, if you have type 2 diabetes and you live in America, you're almost certainly exposed to phthalates. And to my knowledge, there's very little to no research on how those phthalates actually affect you and your disease. So maybe it's possible that if you have patients you're having trouble regulating their glucose, maybe they're being exposed to an environmental endocrine disruptor that's actually contributing to that poor response. And we're not doing that kind of research. And that's really a precision medicine type of research. I think in the environmental health world and in exposomics, we need to start doing more studies on people who have a disease to see how the environment is affecting the disease. This is very different than causation. We're not going to say, I'm not saying in that example that phthalates cause their diabetes. I'm saying that once they have diabetes, maybe exposure to phthalates is going to make it worse, which is a subtle difference, but I actually think is a very, very important question, because as a society, the prevalence of these diseases are getting higher and higher, and all the people with these diseases are certainly getting exposed to the same environmental chemicals as the healthy people. And in fact, they may represent the largest vulnerable population to environment, people who have a chronic disease, and we really do need to study their environments. So untargeted assays, this is basically what a pristine chromatogram looks like. So each one of these are features. Some of the features actually are combined, but features may show you signatures that are specific to a disease. So for example, if you have a disease that changes your metabolism, I would argue that eating disorders such as anorexia or bulimia almost certainly would, you may be able to detect chemical signatures that actually represent the disease. So I think on-target assays have a big role in diagnostics going forward. And that's probably true for cancer as well. But what if we focus only on the cases? Maybe we could tell people, we could start to stratify people as to who will respond to treatment and who won't if we look at their signals that we're finding in these untargeted assays. So we need to start running them in cohorts of patients who have a disease, including cancer, longitudinally, and maybe determine whether or not, if we start early or even before treatment with an untargeted assay, can we predict who's going to have a complication, such as a adverse response to chemotherapy, based on the metabolomic or exposomic profile. Remember, these assays actually contain both metabolome and the exposome. So there are exogenous chemicals in there as well as endogenous chemicals. So we're getting not just the response to, say, a tumor, we're also getting environmental factors or the environmental background that the patient lives in. And some of those environmental chemicals may actually interact with the chemotherapy. And if we actually do these measurements, I think we can start to identify some of those things. And we can do these either in clinical cohorts or even nest them within ongoing or old RCTs if there is a biological archive. So I'm making the argument that study design matters because we really want to focus on people who have a disease. And I'm arguing that we don't really need controls in most cases when we do that. Then there's wearable devices. So everyone's familiar with Actigraph and these different physical activity devices. They're often referred to as part of the Internet of Things. So these sometimes even cars can count as part of the Internet of Things, as well as appliances. These are sensors that exchange data with the Internet. They're interconnected. They can download GPS and physiologic data directly. Remember, if we're making maps of air pollution and temperature and light at night for the New York metropolitan area, and we know where you are because you have an iWatch, so Apple and Google know where you are right now, and we can actually start to map your exposure as you go through these different areas around the city that have different levels of air pollution, different levels of temperature, different levels of light at night, et cetera, et cetera. So actually combining these with the satellite remote sensing data can actually give us a very fine level of detail on the environments that people live in. And then there's even wearable devices that are specific to environmental exposure. So this is actually often referred to as the My Exposome bracelet. It's a silicone bracelet. We've actually started buying these bracelets. The bracelets themselves only cost about 25 cents each. We clean them and we distribute them to patients, or we distribute them to people in research studies, and people wear them for a week, and they serve as kind of a passive sampler. So anything in your environment will actually, that lands on that bracelet, gets stuck to that bracelet, and then we grind it up and analyze it using an untargeted chemical assay, so we can identify all the different thousands of chemicals that you were exposed to during the last week. So wearable devices, we really haven't been applying them in people with diseases. I think actually we could get a lot of interesting information. Maybe we could track activity during chemotherapy. Maybe we would have a better sense of whether patients were actually having really serious responses in terms of their activity to chemotherapy or Parkinson's disease. So maybe we can actually track the number of steps that people with these diseases, like neurologic diseases, have, and maybe that could actually help us to adjust their treatments. Maybe we could measure things like heart rate variability and whether or not they're exposed to air pollution after coronary artery bypass. Remember, air pollution is actually a risk factor for heart disease as well as lung disease. Or we can link the untargeted signatures that we can get from these high-dimensional assays that we run to whether or not they predict high-risk electrophysiology phenotypes and other types of diseases or response to treatment. And we can also leverage GIS, or geographical information systems. We actually started a center for geomedicine in our Institute for Exposomics. So we hired a bunch of geographers, and so I remember Dean Charney was a little skeptical when I pitched the idea to him, but now he seems to like it. Some of them are actually mapping the COVID infection rate in the city to our patient population. So we're actually creating a COVID model that's specific to Mount Sinai patients. So it's a little bit different than the models that the CDC or University of Washington are running, which are for the whole city. The models that our team is doing from this geomedicine program are actually taking patient data from the EMR. And so we're mapping where people are going, and we're using it to predict whether or not we should be staffing people at this hospital versus this hospital, so we can get a fine-grained image of where the infections are so we can allocate resources more effectively and more appropriately. And so it's actually not a research project, it's actually an administrative project. But because we have faculty that are experts in this sort of modeling, predictive modeling, as well as the other types of modeling, this is not technically predictive modeling that I'm describing here, we were actually able to help with the response to the COVID epidemic or pandemic. So there's lots of different measures that you can get of the environment through geospatial analysis and database mining, air pollution, temperature, green space, access to healthy foods. We're starting to look at noise models. Actually, the city of New York actually does have noise monitors up, and we're actually trying to get that data so that we can actually plot a geospatial noise map that actually perhaps could go back in time, which noise is a stressor. Actually, one of my favorite studies, one of our faculty, Itai Klug, actually, you can mine Twitter. And he looked at Twitter data. This is when he used to work at Harvard. And he mined it for mean words. And he plotted the geospatial distribution of mean tweets around Boston and Cambridge. And this is what it looked like in the lower left here. So there's also ways to potentially mine social media platforms to get to the social environment. So I think exposomics is only going to grow going forward because the ability to get this data is actually increasing over time. So how would you operationalize the exposome? So if you like the Ramones, the Ramones once sang about DDT, pesticide. We can use wearable devices which will help us understand patient activity as well as air pollution, temperature, and physiologic data. If we link that to an address history, we can actually go back in time and get lifetime exposure estimates potentially for air pollution, temperature, and other types of environmental data that you can get from satellites. If we got an occupational history, we could create a job exposure matrix to get an idea what kind of chemicals you might have been exposed to. We can take your cell phone potentially one day at the front desk, load it into the EMR, couple it with an untargeted chemical screen and your genome screen, get an idea of all your physiologic data, all of your exposures to air pollution, exposures to other factors. If we get untargeted chemical assays, we're also getting metabolomic or nutritional data. And then maybe there'll be AI running in the background that generates risk scores that integrate both the exposome, things like crime data, the chemicals that we find, the air pollution, and your genomics, and run a genome by exposome analysis that actually tells you with a much higher degree of precision what your risks are for certain diseases. So Neutral Milk Hotel is another one of my favorite bands. So some examples of exposomal precision medicine projects might include looking at phthalate exposure and cystic fibrosis. So people with cystic fibrosis have both diabetes and lung disease. Phthalates actually have been associated with diabetes and lung disease. So maybe phthalate exposures in patients with cystic fibrosis is an important precision medicine question. Maybe, as I mentioned earlier, we should be looking at environmental obesogens in patients with diabetes. Maybe we should be looking at exposures to neurotoxic metals such as lead or mercury or arsenic as a modifier of, say, Alzheimer's disease severity and progression. Maybe some of the patients that progress more rapidly than others are actually exposed to neurotoxic chemicals in ways that right now is a big unknown because we're not measuring them. Maybe we should be looking at air quality in surgical ICUs. Maybe some of the mortality rate or the complication rate is actually due to poor indoor air quality. As far as I know, that's not being done in any of the ICUs. Untargeted chemical assays might actually, as I mentioned, be a way to detect eating disorders such as anorexia or bulimia. In fact, this is something this is a list I just came up with off the top of my head. This is such an open field in terms of environmental risk factors in patients with diseases, as opposed to looking at the cause of those diseases, but actually looking just at the people who already have that disease, that you could actually create lists of studies very, very easily because very, very little research has been done on people who already have a disease. And unlike causation research, the field is so open that most of these ideas are very low-hanging fruit. So I'm getting near the end. So exposomics is, I hope I've convinced you, is very different than almost any other omics science. It actually is going to require the integration of multiple data types. I think questionnaires are always going to be important. So when Job Exposure Matrix is an example of a questionnaire to try to get your occupational history. But also we're going to link it to GIS data to understand your exposure to air pollution, green space, and noise. I think photos are going to be important. My daughter takes a photo of her food almost every night and sends it to me and whenever she cooks. I think eventually I know people are working on algorithms to try to get the nutrient content of those, but also things like cleaning products, all kinds of things that are in the household people can take pictures of and send to you, and that may give you some idea of what their local environment is like. There's always going to be a role for assays, whether we use urine or blood or exhaled breath condensate. One of my faculty, Dr. Manisha Rohrer, actually developed an assay using teeth. Teeth actually grow like trees, and they have rings in them that are analogous to the rings, growth rings of a tree. And actually, he can identify chemicals in those growth rings and attach a calendar date to it. So this works really well with baby teeth. So teeth that fall out normally, if a parent gives you the baby teeth, he can actually map chemical exposures going back to pregnancy up until the time that the tooth fell out. And then there's going to be high throughput assays. The untargeted assays are going to get better and better. The technology is actually quite good right now. I think what we really need is growth in the informatics. We're identifying hundreds of thousands of reproducible features on these chromatograms, but we only know a fraction of them as to what they are. As time goes on and as people are data sharing, that fraction is going to grow more and more, and eventually we're going to be able to measure all 100,000 of them. And then there's going to be wearable devices and mobile devices that are going to tell us both where you are and what you're exposed to and how active you are, and link it to physiologic data at the same time. So in the future, exposomics and precision medicine are going to enable diagnostic tests. We're going to be able to understand subpopulations that have different prognoses. We're going to understand the relationship between a patient's chemical, nutritional, physical, and social environment and the disease progression and prognosis. And I think we'll be able to identify optimal treatments based on one's exposome and reduce the variability of exposures or reduce the response variability of a treatment that might be due to exposures, or to reduce side effects and hopefully improve compliance. So the precision medicine programs are going to look more like this. This was the one website I was able to find that actually talked about environment in their precision medicine program. It wasn't purely a genomic one, where they actually tried to factor in not just genomics, but things like medical history, environment, and behavior. So our laboratory is actually funded by National Institute of Environmental Health Science, but it's also co-funded by NCI to measure these untargeted chemical assays and targeted chemical assays in NCI funded studies. So if you have a study, talk to your program officer and see whether or not you qualify to use here, and we can actually measure untargeted chemical assays in some of the targeted panels that can measure up to 150 different chemicals in your extant biological samples. And you can look at that data to see whether or not it predicts response to treatment or disease causation. And I think our exposomics, I think, will complete the precision medicine puzzle if we ask the right questions. That's my last slide.
Okay, so this was a great presentation. We can use our reactions to clap. It's the best we can do right now. So yeah, I'm gonna clap. Okay. So we have a few questions, but I will start with my own question. So obviously, taking into account all these factors is making things more accurate, but at the same time, more difficult to understand. So how do you envision, or what do you think the computational powers will need to be able to integrate all this data?
Yeah, there's a tension between the size of the data, the dimensionality of the data, but also there's a biological component to this. If you model the data correctly so that if there really is gene environment interaction going on and you ignored the interaction and you're modeling incorrectly, you're actually adding noise. So if you model it correctly with the interaction between genomics and environment, I actually think you'll find that you're going to have more power, not less. I think it's a misnomer to think that just because you're looking at interaction, you need more power. It depends on whether or not, it depends on the prevalence of the interaction in the population, it depends on the size of the interaction effect. So it's not necessarily the case that you actually lose power by looking at interactions. I would actually argue probably gain power because
Okay.
I do believe there's a lot of interactions out there that are undiscovered.
And regarding the modeling, like the technology or the knowledge is there to be able to integrate all this data?
Oh, yeah, definitely. People are doing what they call GWIZ, genome-wide interaction studies now. I think the challenge is that environment is hard to measure and it's constant. I think the simplest way to start would be a cumulative environmental model, but biologically, we know that there are life stages in which you're more susceptible to environment. So if you get exposed to lead when you're 30, it's less toxic than if you get exposed to lead when you're 2 years old, because your brain was developing at 2 and it really is sort of set in stone, so to speak, at 30, so that the effects tend to be lower. So one of the things, exposomics, or one of the great challenges in exposomics is it's possible that environmental factors, in fact, the whole field of DOHAD is based on this, that occur early in life are predicting the heart disease and the Alzheimer's disease and the cancer that you're getting 30, 40 years later. So one of the greater challenges in exposomics is being able to go back in time. But a lot of the geospatial modeling and the satellite remote sensing modeling and the database modeling does go back in time. Dr. Rohr's tooth biomarker goes back in time. And in fact, he's done some studies with adult diseases where they have biobanks. So he's about to publish a study on ALS, Lou Gehrig's disease, where when the patients donated their brains to science, so to speak, they also were able to get a tooth. And your teeth were formed in roughly the 3rd trimester of pregnancy in your mother, your permanent teeth that you have right now. And there are rings in there that he can mine to try to figure out what were the exposures that you had early in life. So there may be ways to go back in time that we don't quite understand yet.
So we have actually 6 questions lined up. So I will start with the question from Dr. Parsons. So what are the best questions to ask for cancer risk based on feasibility?
I think if you have extant biosamples in randomized controlled trials, we could run untargeted assays and you could see whether or not there were signatures that predicted response to treatment. I think that would be a low-hanging fruit that could be very useful, actually, and you could combine it with genomic data as well.
Okay, yeah. So Nihal is asking, how do you assess time change in exposome over a period long enough to create the targeted effects?
Well, I have the advantage of being a pediatrician. So when I do a lifelong exposure assessment, I may only have to do 5 years. Okay. So if I was doing Alzheimer's disease research, I might have to do 80 years. But the advantage that I have is it's a relatively short time frame. We developed a method called distributed lag regression, which has actually been around for many years, but was used more for time series analysis. But when you have data on exposure that's very temporally dense, so air pollution data you can get at a daily level, you could aggregate it by month and you could actually do distributed lag to see whether or not there are life stages at which the air pollution measurement predicted the health outcome differently than other life stages. So it actually is a good way to try to identify critical windows. The data structure of Dr. Rohr's tooth biomarker is very similar to that. So we've actually used distributed lag regression in the tooth biomarker data as well.
Okay, yeah. So Jerry Chipuk is asking whether you can comment on how these studies inform governments on policy.
Great question. I don't do policy, and so I don't have a great answer for that, but I do think environmental health does lend itself to policy questions in general because you're talking about regulation when you're talking about air pollution and chemicals. So a lot of our work it is relevant to policy, but and it informs policy. But I personally am not an expert in policy making, so I just do the research. So it's probably not a great answer, to be honest.
Well, I mean, you cannot do it all. So, and Natasha Kiprianou is asking, what is the contribution of hormones from environment and tissue microenvironment on exposomes, specifically in cancer?
Oh, that's a great question. And the value of the untargeted assays is we do pick up a lot of different hormones. Certainly the non-protein hormones are picked up because they're typically small molecules, the steroid-based ones. So when we run those assays, we can give you hormonal data on the small molecule hormones, and you can actually do those analyses. And when I think you're measuring, I don't know what the correct word is, but I think it's more biologically correct to measure multiple hormones at once than to look at a hormone in isolation. And the example I sometimes give to students is if I measured your thyroid stimulating hormone and it was elevated, there are scenarios in which you're hyperthyroid and there are scenarios in which you're hypothyroid. So in order to really understand the biology of hormones, you have to measure all of them that are relevant to a pathway. And actually these untargeted assays can get to that.
Okay, so Quan Lin Juan is asking, are the exposome measures for patients available in Sinai databases with linked MRNs, biobank IDs, etc.?
We are not a CLIA certified laboratory, so our data are not used clinically.
Okay, so I will just take the questions from Kenan and from Tiffany because we just reached 1 p.m. So Kenan Onel has two questions. The first one is, with all the technologies, analytic pipelines, and orthogonal data sets, how scalable across a disease is exposomics? And the second question is, how useful are animal models in assessing exposomics in human disease?
So for the first question, exposomics is a young science, so we are not really able to measure the total exposome across the lifespan, even of a child. So our databases are big. They have millions of databases, but they're not too dissimilar in size to genomic databases. I think as the technology gets more developed, particularly with wearable devices, wearable devices aren't that old and they only measure environment concurrent. So the oldest data you can get on a wearable device depends on when that wearable device was invented and operationalized. So over time, these databases are going to get bigger and bigger because they're basically a prospective cohort study. But I do believe the computational infrastructure is going to parallel that because it's certainly been the history of computational infrastructure in this country. It's as opposed to animal studies, when you have a controlled experiment, you're trying to control everything except whatever your intervention is. What's interesting is there's lots of examples of animal studies in which environment wasn't controlled as precisely as they thought. And I think there may be a role for exposomics in actually determining whether or not interventions truly are the only difference between groups. If you were to run an untargeted assay, you may find that there were other things different between groups. So I think there may be some added value to some of these in animal studies.
Actually, the last question from Tiffany Martin is related to the need or not need of control samples in these studies. And if they are not needed, how do you remove the background or how do you identify what is specific to a subgroup?
Well, in the studies I was advocating that you take a cohort of patients and it's be just like any other prospective cohort, except to get into the cohort, you had to have a disease, and then you follow them over time and you measure their environmental exposures and you look at whether or not the environmental exposures modify the disease progression. It's not dissimilar to the way lead research was done in the 1970s and 80s, where we took a cohort of children and measured their blood lead and followed them over time and eventually measured their IQ. So it's very analogous to that. So I think if you use that design, it would be good for answering that kind of questions. There are certainly questions for which you will still need controls, but the kinds of questions I was advocating for would not need controls, but there's certainly going to be questions that do need controls.
Okay. Well, thanks a lot, Dr. Wright, for this outstanding presentation. It was very different from what we normally have in this seminar series. So therefore, I think it was very enlightening. And I hope to see you all next week. We will have Dr. Augusto Villanueva telling us about his latest research in liver cancer. Thanks a lot and take care.
Thank you. Thank you, everyone. Bye-bye.
Bye-bye.
Thank you.